Is that better?
Yes.
Okay. Seeing if Deb is, my second presenter is Dr. Deb Gomes. I'll see if she's available. Might be more polite to let Deb go first.
Not online yet, no.
She's not on. We're a bit early. We're a couple of minutes early. Poor Deb has got a cold as well. But Eve, I don't think we've met before.
No.
Where do you work?
I'm the comms officer with ANZSA.
Oh,
Yeah.
very good.
Lovely to meet you.
It was nice to meet you. Yeah.
I'm also a bit sick as well. I've had a sick week, but I've jumped on for Journal Club. But
very nice.
Sick. Everyone's sick this week.
Oh, we can't catch anything from anyone.
No, luckily.
Angela, how do people get involved with the ultra-low cancer group? You know, these projects.
Oh, I can talk you online. Yeah.
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 Okay.
Hi, everyone.
Lovely to see you, madam.
And you too. I'm on my phone because our internet is a bit dicey, so I'm hoping this doesn't die.
Are you looking forward to the ISS? Oh, it's frozen. No, it's frozen. We are going to the International Skeletal Society in Portugal next month. Fiona's very active there. Here, you're back. Oh no, it's playing up for Fiona.
Position. Might be my position. Am I back yet? Hello?
You're back now. Yep, you're back.
Oh, good. I think it's the position. I'm going to stay just sitting here now. Hopefully that'll work.
Okay.
You're not going to Vienna?
You are.
Yes, I am. Are you?
No, I decided that I couldn't do both. So, but
okay.
It's a very intense program in Vienna.
Yeah, I know.
Looks really good.
No.
Looks really good. Here is Dr. Gomes. How are you, Deb?
Hi, I'm getting better.
Oh, thank you so much for doing this.
Pleasure.
So, Angela, are you chairing or my chairing?
Yes, yeah, no, well, why don't we get started? It's on 5 o'clock. So welcome everyone to our 4th session of the Journal Club today. So today will be 2 presentations from the Adelaide team, pathology presentation. So thank you for doing that. And before we start, I'd just like to acknowledge the traditional custodian on the lands on which we are meeting today. So I'm on Camarago land, 65,000 years of culture, one of the oldest one in the world. I pay my respect to the elders, past, present, and emerging, and recognize the deep connections to the land, sea, and sky of this beautiful country. So I'll hand over to you, Gelareh.
Thank you. Thank you very much. Thank you very much for the opportunity to present today. I've got the pleasure of introducing my dear colleague, Dr. Deb Gomes, who's a new consultant in surgical pathology at the Royal Adelaide Hospital, working with me on the sarcoma MDT. Deb, do you want to go first? You're on mute. Do you?
I'm happy whichever way you prefer. I don't mind.
But why don't you go first, given that you're also not very well, just in case you need to leave early. So I will stop sharing, and if you want to start us off, please.
Let's see, and hopefully you can see my screen. Oops.
Not yes yet.
It's getting there.
Getting there. There we go.
You see
and
now?
If you put it on full screen, is it on full? Yeah, it is on full screen. Terrific. Is it on full screen?
Okay, it is now, right? Yeah, excellent. Okay.
No, I can't see it now.
Oh, you cannot?
No, it went.
Okay, let me try again. Can you see it that way?
No, not yet.
Okay, I'll share again. Just a sec. Sorry. Share screen. Allow.
And here, share entire screen.
It's gonna do it. Yes, go
yeah?
ahead. Yeah.
I'll try to put full screen. Hopefully it still works. Yeah?
Very good. Yes.
Okay.
Thank you. Thank you.
Excellent. Thank you everyone for letting me present today. So I'll be talking about the UK guidelines for the management of bone sarcomas. It's based on this paper here that was published by the British Journal of Cancer. It was published in 2024. It's an update of the British Sarcoma Group guidelines that was originally from 2016. It is kind of a reference standard for the clinical care of UK patients with primary malignant bone tumors and giant cell tumors of bone. It's a very extensive paper, so I had to select a few things. So if you want to know more, there are more details on the paper. So basically starting with the incidence and epidemiology. So the primary malignant bone tumors, they are 0.2% of all cancers with an annual incidence in Europe of 8.5 in 1 million people. 5% of childhood cancers in Europe, mostly osteosarcoma and Ewing sarcoma in this age group. And in patients that are less than 5 years old, the bone tumors are most likely metastatic neuroblastoma and eosinophilic granuloma instead. Whereas in adults, especially those more than 40 years old, a bone lesion is more likely to be a metastatic carcinoma or a hematopoietic malignancy. Those lesions in the bone are classified based on morphology. So the WHO separate them in subtypes such as chondrogenic, where we have the chondrosarcomas, osteogenic, we have the osteosarcomas, notochordal tumors, we have our chordomas, for fibrogenic, fibrosarcoma, vascular lesions such as an angiosarcoma, osteoclastic giant cell rich, we have giant cell tumor of bone, and we have a miscellaneous of other mesenchymal lesions such as adamantinoma of long bones, leiomyosarcoma, undifferentiated pleomorphic sarcoma, and Ewing sarcoma and other round cell sarcomas, those that are newer and molecularly defined. Patients with bone tumors, they normally present with pain. It may present with a lump or a swelling. The bone pain, the intensity is variable, but whenever there is night pain, that is a red flag. Sometimes they can present with pathological fracture or spinal cord compression or neurological symptoms, and they will require an urgent X-ray. And if the X-ray shows any of the following, the patient will need further investigation. So things like bone destruction, new bone formation, periosteal swelling, or soft tissue swelling. However, if the X-ray is normal, that won't exclude a primary malignant bone tumor. So if the patient has persistent pain or a mass, they're still going to need urgent MRI, or can be right away referral to a bone sarcoma center. So basically they separate by age, which in patients less than 40 years old, they recommend you to prioritize urgent referral to a bone sarcoma center and only do investigations that won't delay the referral. Whereas when the patient is more than 40 and metastatic carcinoma is more likely, then it's reasonable to do some investigations before referral, such as CT chest, abdomen, pelvis, whole skeletal imaging, and myeloma screen. And then once a single bone lesion is proven, they can be referred to the bone sarcoma center. It's recommended to refer before doing a biopsy because those should be done at a bone sarcoma center because poorly performed biopsies can compromise treatment. As you know, they're going to have to make sure the biopsy tract can be excised, so should be done in a proper center. And also the biopsy will need to be reviewed by a specialist pathologist within a bone sarcoma MDT. Some principles from the biopsy, as I said, performed at a bone sarcoma center. It's going to need cross-sectional imaging to identify which area is the best for the biopsy and to plan the approach. Should have minimal contamination of normal tissues. They should mark the biopsy tract clearly with a small incision or a tattoo. And if it's a core needle biopsy, ideally it should be guided by ultrasound, X-ray, or CT. They recommend samples to also be sent for microbiology other than histology, and also for cytogenetic and molecular genetics studies. And they say that all patients there should have access to whole genome sequencing for their tumors. If possible as well, some samples should be snap frozen in a tumor bank, which will allow for future research, of course, if the patient consents. The diagnosis will be confirmed after a discussion in a bone sarcoma MDT, which will include a surgeon, radiologist, pathologist, oncologist, all of them with access to all the clinical information and biopsy material. And a little bit about the management of those tumors. Basically, a patient with a primary malignant bone tumor should have a key worker and should be on a specialized MDT. And they talk about how the bone sarcoma MDTs should be made. They should have sufficient core members, so there's like minimal numbers from each specialty, and there's a minimal numbers of patients that should be treated each year as well for the MDT to be considered adequate. And the patients should be supported to participate in clinical trials as well. So the treatment will include chemotherapy, which is a standard for most osteosarcomas, also used for Ewing sarcoma and other round cell sarcomas, and for all the high-grade sarcomas of bone. In case of chondrosarcoma, chemo can be considered in the dedifferentiated or mesenchymal types, and the usual sequence goes neoadjuvant combination chemotherapy, followed by local treatment with surgery or radiotherapy and post-op adjuvant chemotherapy. The surgery has to be done by a core member of a bone sarcoma MDT in a commissioned center. With the decision of when to do the surgery and what type of surgery is going to happen after discussion on the MDT. The aim will be to remove the whole tumor with adequate margins whenever possible. And for Ewing sarcomas, they should aim to remove the tumor volume at presentation, so not the tumor volume after the treatment, which may shrink. They recommend marking the closed surgical margins with hemostatic clips and the resection specimens to be oriented to allow reporting of the margins. Radiotherapy is in primary malignant bone tumors is used selectively. For Ewing sarcoma can be used as definitive treatment or combined with surgery, but for non-Ewing primary bone sarcomas, the use is more limited, mostly if surgery is not possible or in the post-op of selected cases where there is a high risk of local recurrence. In all tumor types, radiotherapy has a palliative role. Pulmonary metastatectomy can be done for oligometastatic disease, aiming to remove all lesions, of course, still keeping pulmonary function as far as possible. And traditionally, thoracotomy is preferred, but the studies did not show any clear advantage over thoracoscopic resection. They talk about specific treatment, so particularly going by types of tumor. I didn't include all of them, but just some. For chondrosarcoma, it's the most common primary malignant bone tumor, affecting people mostly between 30 to 60 years old, mostly long bones, and most of the tumors are low grade. And the treatment of choice for most is surgery. In the case of an extremity ACT, you can do initially observation, and only if the symptoms are progressing or if the patient is symptomatic, you may go for surgery, which can be just curettage plus or minus surgical adjuvants, such as high-speed burr, cryotherapy, or given that there is a chance of recurrence, some surgeons may prefer go straight away to excision instead of curettage. In the case of low-grade peripheral chondrosarcoma, the tumor should be completely removed with an aim to leave a covering of normal tissue. For higher-grade chondrosarcomas and for all chondrosarcomas of the pelvis and axial skeleton, then those should be removed with wide margins. And they mentioned that in the pelvis, for example, a 2 millimeters margin is associated with lower local recurrence rates. This is just a little bit about patients with multiple benign osteochondromas or enchondromas, those with Ollier or Maffucci disease. They are at risk of developing secondary chondrosarcomas and should receive counseling and follow-up. Radiotherapy, again, just in some specific situations, unresectable disease can be used adjuvant after surgery if the margins are positive or very close, and for palliation. And in the case of skull-based chondrosarcomas, a high dose of radiotherapy with surgery combined can achieve a high local control rates of 80 to 90%. Chemotherapy, basically osteosarcoma chemotherapy protocols can be considered for mesenchymal and dedifferentiated chondrosarcoma, but the survival is unfortunately still poor. For osteosarcomas, those are the second most common primary malignant bone tumors. They are 4% of solid cancers in children, 3% in teenagers or young adults, and also there is a second peak around the 7th to 8th decades. And they mostly affect the metastasis of extremity long bones. For the conventional osteosarcoma, which is the high-grade osteosarcoma, the treatment recommended goes with neoadjuvant chemotherapy, followed by surgical resection, followed by adjuvant chemotherapy. And this increases the survival from 10 to 20%, which is for surgery alone, to around 60%. If possible, again, patients should be enrolled in clinical trials. The chemotherapy, if the tumor is resectable and the patient is up to 40 years old, the most recommended regimen is high-dose methotrexate, doxorubicin, and cisplatin. Whereas if the patient is more than 40 years old or cannot tolerate high-dose methotrexate, some regimens without methotrexate may still be effective. The surgery, again, will aim to completely remove the tumor, preserving function where possible. And wide surgical margins will reduce the risk of local recurrence, but sometimes it's not possible depending on location and size. If there is a good histological necrosis rate after chemotherapy, which will be necrosis in more than 90% of the tumor, then closer surgical margins can be considered. Adjuvant chemotherapy in osteosarcoma shows a significant survival benefit. The regimen may be the same as I mentioned for the neoadjuvant, or it can be modified. And they mentioned on the paper that adding the immune modulator liposomal muramyl tripeptide has shown statistically significant survival advantage. So this is approved in Europe for patients less than 30 years old, which have completely resected and localized osteosarcoma. Adjuvant radiotherapy, same thing, mostly for selected axial tumors, which have a high risk of local recurrence, and further surgery is deemed unacceptable. Can also be used for inoperable axial primary osteosarcomas for local tumor control. For the low-grade osteosarcomas, which will be the paraosteal, central, periosteal osteosarcomas, those have lower metastatic potential, so treatment will be complete surgical removal. But if there are high-grade areas, the outcomes are poorer, and chemotherapy may be considered, although the evidence is limited. For metastatic osteosarcoma, if it's possible to surgically resect all disease sites, this can be done, and the patient may be treated with the same chemotherapy regimens as for non-metastatic osteosarcoma. And there's approximately 30% of primary metastatic osteosarcoma patients, they become long-term survivors. If the metastatic disease is inoperable, then they should balance the toxicity of the therapy with the impact on the quality of life. For Ewing sarcoma, so basically it's the second most common primary malignant bone tumor in children and adolescents, with a median age at diagnosis of 15 years old, but as you know, can also occur sometimes in adults. Mostly affecting the long bones and also pelvis, ribs, and vertebral column, and they're all high grade. The 5-year survival rate is less than 10% if only surgery or only radiotherapy is used. However, multimodality treatment, including chemotherapy, improves the survival to almost 80% in localized disease. and to 20 to 40% in metastatic disease. For Ewing sarcoma that's localized, the treatment regimen recommended will be neoadjuvant chemotherapy, followed by local therapy, followed by consolidation therapy. And the chemotherapy regimen that they consider the preferred first line will be VDC and IE induction, followed by IE and VC consolidation. And they also describe that if the treatment, if a greater treatment intensity is used, which is a 2-weekly interval compressed treatment, the outcomes are better compared to giving it 3 weekly. The surgery should, as I said, aim to remove the primary tumor completely, and it's the tumor volume before treatment that you should aim for. And additional radiotherapy after the surgery is to be considered if there is a poor radiological or histological response to chemotherapy, when the margins are inadequate, if the tumor is large, or if it's on a high-risk area like the pelvis. And radiotherapy can also be used as the definitive treatment if the tumor is inoperable, if the surgery is too morbid or with risk of significant complications, or if the prognosis is poor, such as in the case of widespread bone metastasis. Chordoma develops from persistent notochordal elements, and a location most commonly is in the sacrum, 50%, on the skull base, 30%, and on the mobile spine, 20%. The recommended treatment for chordoma is en bloc resection with a margin of 1 millimeter or more. And if it's in the sacrum, involving the S4 nerve root or below, surgery is recommended. Whereas if the chordoma is above this level, the morbidity increases, and then treatment should be discussed and considering other options such as radiotherapy. Chordomas of the skull base and cervical spine, R0 resection is rarely possible, so should aim to remove the tumor as completely as possible while still preserving the neurological function. And a high dose of adjuvant radiotherapy may be beneficial after surgery when there is positive or close surgical margins. And proton beam therapy or carbon ion radiotherapy are promising alternatives. And the last one is the giant cell tumor of bone, which is 12 to 15% of the primary bone tumors in England, affecting mostly patients between 20 to 40 years old. At the epiphysis of long bones is the most common site. And it's usually locally aggressive with a high risk of local recurrence, which is up to 50%, and around 5% of the lesions metastasize to lungs. If you have a giant cell tumor of bone, they recommend excluding a brown tumor of the hyperparathyroidism first with serum calcium levels. And if the tumor is resectable, patients should go for surgery with en bloc excision showing lower rates of recurrence as compared to intralesional curettage. Denosumab is indicated when surgery is not possible or is too morbid, if the patient has metastasis, and also in selected cases before surgery, such as when they want to solidify the soft tissue component to make the surgery a bit easier. If you attempt to do curettage after denosumab, that's difficult, and the risk of recurrence is higher. So if you give denosumab, a complete resection is preferred afterwards. And with denosumab, the initial control is excellent, around 96%. But most tumors will recur after you stop the drug in around 9 months. So if it's possible to do surgical resection, it's still recommended. Radiotherapy is used when surgery is too morbid and adequate margins is difficult, with local control rates of around 80%. And chemotherapy has been used in some cases in giant cell tumors of bone that are unresectable and advanced, and when they are not responding to denosumab, but there are no randomized clinical trials, so it's not a standard of care. For metastatic disease, those patients may require lifelong treatment with denosumab. Surgery for pulmonary mets are usually not performed for those tumors. And if the giant cell tumor of bone is malignant, patients do not benefit from denosumab. So they may receive combination chemotherapy with the same protocols as for osteosarcoma and other high-grade primary malignant bone tumors. And that's the article, and thank you.
Thank you. Thank you very much, Deb. It's a huge amount of ground to cover. And thank you. You did an excellent job of highlighting some of the important contributions of the paper. Given that we've got a multidisciplinary audience, I just wanted to ask people, how does the recommendations of this British article sit with practice patterns for you? Angela, were there anything that struck you as out of kilter with what we do in Australia, radiation therapy wise?
No, intraoperative therapy are very straightforward, but the intraop definitive role really is in Ewing sarcoma or those skull-base chondrosarcoma, chordoma, that is the role for definitive radiotherapy. So I would agree with the recommendation. The beginning of this, there were a lot of talk about focus on second opinion, management of sarcoma, specialized center, or what they call commission center. We obviously strongly agree with that. ANZSA has our own guidelines looking at the evidence for surgery, radiotherapy, second pathology opinion by specialized sarcoma experts.
Yeah.
There were a bit of chat in the chat box too about slightly different treatment with osteosarcoma. Is that right? Well, one of the oncologists like
yes, one of the oncologists. Can you walk us through some of the things that struck you as novel or needing a bit more discussion by our group? We've got Vivek Vivek, do you want to please go ahead?
Yeah, so I think, I mean, first of all, do you think that in any of these guidelines, there are any practice-changing points for us in Australia? That's my first question to the presenter.
From my point of view, as a pathologist and fairly new on the sarcoma and bone MDT, nothing has struck me as completely different from what I see in the discussions. But there might be some details that you guys will be more able to tell. But I didn't notice any big differences.
Yeah,
I guess